We're going to hear about a project and its origins, its framework, some of its accomplishments so far, and what its future may be. And Kedar, if you would lead off, please, with some stage setting, the origins of this amazing effort and what some of its current activities are.
Well, we'll leave it to the audience to decide how amazing it was. But first of all, it's great to be here. And wonderful to be part of the forum again. And thank you to Daniel and to Rich and to the ABIM team for inviting this conversation to be part of the forum. Don, you're right. This started perhaps right before or right around the last forum. So to those of you that are new to the forum and this incredible gathering, this is an example of something that can come out of such a gathering, the power of being together. But in the forum here last year, or soon thereabouts, we started a conversation about, we'd spent a lot of time, I think, in forums like this, identifying ways in which health systems struggle with trust. And of course that, for me, started to invite this question of, well, who gets it right? Who's doing this well today? And who can we learn from that we might be able to process this question differently around? So with the generosity of the foundation, thank you, Daniel, thank you, Rich, thank you, foundation leadership, we were given a grant at IHI to study that question, to go ask a group of health systems who were in some ways objectively high trust institutions, what they were doing differently, what they were doing that was creating or engendering that kind of trust. When we started to look at this question, it became very quickly apparent to us that it was very difficult to tell. As you could probably imagine, the measurement of trust, somebody identified this earlier in the first day, I think, we started talking about how much it's the sort of enterprise of trying to measure trust is complicated. So there's very limited direct measurement of trust. And so what we had to do is look at some proxies. And we had actually a large team of folks that started to think about what sources might look like. And we ended up with 3 primary data sources: HCAP surveys, certain questions from CAP surveys, trying to understand the experience of patients. And our thought around this was that those that felt listened to or heard or that felt likely to recommend an institution were in some ways encountering a likely high trust situation. We also looked at something called the NRC Loyalty Index. This is NRC Health's index. It's a composite measure of engagement, experience, accessibility, those kinds of measures. And again, we thought if you're loyal to an institution, you're representing that institution externally, you probably believe in the institution in some ways, and you might trust it. And then lastly, we looked for a measure of internal trust to an organization. And we looked at safety culture, trying to understand psychological safety within an organization. So we looked at the public, reasonably available SOP scores. And we had a lot of help on this. Daniel and Susan Edgerton-Levitan, I see you somewhere in the audience, but I would affectionately call you guys co-PIs of this grant. And a very helpful team that surrounded this, including folks that are also here, Jessica Green and Dawn Johnson, if you get a chance to see them, along with an IHI team that started looking at this data. And what we were looking for was top decile performers in all 3 of these objective instruments. And first of all, the first observation, Don, is that there's limited correlation between the top performers in the NRC Health Index, the HCAP surveys, and the SOP surveys. So very few institutions, hospitals, rose to the top of all 3 of those. But there were a few that did, and those were the ones that became the subjects of our further investigation. Now, one pattern we found was that there was 0 safety net institutions in that group, no federally qualified health centers. And so that led us to want to augment the data pool with some contacts and connections that we had, because we were really interested in some of the issues that Dr. Corby was talking about yesterday from this stage. So we wanted to make sure that we had representation in the systems that we were interrogating and looking into. So we added a couple of other institutions to that list. And then we interviewed the leadership of these teams. We said, what made you CEO, CNO, CMO, chief of HR, community population health folks, patient family advocates. We said, what makes this institution a high trust institution? And for the most part, they all looked at us kind of with surprise. We're a high trust institution. They're like, what are you talking about? And so we showed them the data, their data, said, hey, look, you actually did stack up well in these objective measures, and what do you think you do? Once they got past their surprise, they started telling us a story of trust. And in fact, there was a bit of a pattern through it. So what we ended up with is a pattern in our interviews with over 60 or 70 healthcare executives and leaders and patients and family members. What they started to describe was a set of actions that the institution was taking that fell into these buckets. We've talked about this here in this room a lot, this notion of acknowledgement and apology, truly listening to stakeholder groups in the community or within the institution with clinicians, truly addressing the problems that are surfaced. Eric Way talked about in a very vivid example from the stage the other day of the kids who were passing the vending machines on their way to surgery after being NPO, truly listening to the people that were in the work and addressing the problems that they were finding, and then closing the gaps and making sure that those gaps were closed by going back to the community or going back to the clinical community and saying, does this solution adequately meet your specification for a solution? And then lastly, the organizations that we met and we worked with and we interviewed were doing something different. It wasn't just acknowledgement, it wasn't just addressing the proximate problem, but they were building systems to continuously listen to either the patient community or the provider community, and build systems for doing that and continuously addressing the problems that they found. And this framework, it turns out, is a reference actually to a framework from William Darity and colleagues who developed the ARC framework, the Acknowledgement, Redress, and Closure framework, which was a framework that was originally designed to address reparations in the country. So the framework that we ended up using, or the pattern we ended up documenting, was actually a reparative and restorative framework that came out of the reparations literature.
Can you slow down for a minute on the ARC framework, the elements of it again? What's that framework?
Sure. Acknowledgement of the past breaches or the past challenges around trust, the past harms that might have been created. So from the clinical community, we heard all kinds of stories about administration and staff clinicians facing off and fighting in different ways. I think Eric, again, to reference the New York Health and Hospital story, provides stark examples from the stage here of the Death Star or Central Command or whatever he called it. But those kinds of past breaches of trust were acknowledged and apologized for. Then you would take specific action to try to redress or address those challenges that were found. And then you'd go back to the affected community and say, was this solution that we put in place adequate to solving the problem that we had initially identified and acknowledged? So it wasn't enough to just listen and acknowledge and apologize. You had to do something about it. And then you had to follow up with the community and say, did what we did, was that enough? And those were the three elements of the ARC framework that Darity had originally created. Darity and Mullins had originally created, and we were now hearing that pattern over and over again in the interviews that we did with the informants that were from these high trust institutions that we found. And that's what our approach is at IHI, is to study these bright spots, positive deviant analysis, which is what this is otherwise known as, and then try to deduce a framework from what they have come up with, which is what you see here on the screen, and then prospectively apply that to new settings, to novel settings, and that's where these two gentlemen come into the story.
So you've started now a collaborative process among organizations. Are these the ones that scored high, or the ones that? Okay.
Let's go with that.
Well, I could lie. No, part of the idea is that you taking the framework as it was and applying it to the institutions that we derived the framework from wouldn't necessarily help us test or validate the theory. So the idea was to go to new institutions who perhaps, you can speak for yourselves about how you're doing on trust, but who would benefit from the framework, let's put it that way. And that's what we did. So okay. Oak Street and
so Fred Cerise, head of UT Southwestern Parkland, and Ali Khan from Oak Street are two participants in the collaborative that has now emerged. Ali, do you want to start? Or I guess you already started. What's going on? Why are you in it, and what are you trying to get done?
I mean, I laugh only because I think we don't even know half of the measures. So I think it's interesting for us. So we are we are not in one city or one metro. We are a national network of primary care centers, almost entirely in structurally marginalized communities with incomes of 300% or below the FPL. Our teams are usually 70 to 75% Black, Brown, or Indigenous, or immigrant, right? So reflecting the communities that we serve. We are across 21 states, and we are fully capitated at risk. So a lot of the work that we do is shifting the locus of control and primary care from sort of reactive of whatever comes in to very proactive. And we are also for profit, right? So like in all of these ways, we are like attempting to make a lot of different changes at once that can feel, that I think we hypothesize can obviously introduce a lot of sheer forces for teams, right? Even when we are operating with panel sizes of 400 to 500 at the clinician level, when we got large care teams, we think we're well resourced. But for us, I think the question becomes, particularly Don, from a profit status perspective, that we have to unpack this aggressively in order to understand and actually demonstrate that like what we are doing is, from a care delivery perspective, is equivalent or not better to what is happening from our non-for-profit or other peers, particularly given the communities that we serve. And we spend a lot of time thinking about the scar tissue against the medical industrial complex that's built up in the communities that we serve. So for us, this was essentially trying to call out our own BS of like how deep we think we're doing all this stuff, but if our teams don't understand this, then we were super excited about this process when it came out, because of the opportunity to really say, to either validate or challenge our own deeply held assumptions and then move forward.
So I mean, why? What's the deeper motivation for doing it then?
Can I ask you another question too, to go along with Don's, which is, did you know that there was a potential trust problem that you were dealing with? How did you know?
So I think two pieces to this, right? I think one, we know from our workforce and how we interview them and how we track over time from an engagement standpoint, that folks are incredibly motivated to the mission of bringing primary care capacity and in a proactive way to the communities that we serve. So like from a very high level top of funnel perspective, people identify with that work, and that work is to actually make that kind of clinical impact at the last mile. We're not New York City Health and Hospitals, we're not Parkland, but we are this other agent. And people are attracted by that and by the idea of doing things differently in primary care. But we also know, and especially like through the pandemic, as we continue to expand and like try to open up a bunch of access in a bunch of different places, I think 70 centers just in 2020 and 2021 alone that were new, that our teams felt those sheer forces. So like whether we hadn't measured trust, we could see engagement differences, right? So we could see that people would believe and have faith in their managers, but not necessarily believe or have faith in the overall like enterprise. And our hypothesis going in, which we will get into, which actually turned out to be wrong, was that we thought, is it profit status, right? That for us is that the barrier for a lot, when we have a lot of physicians or nurse practitioners or other clinicians coming from federally qualified health centers or coming from public systems, is it that piece where like just the question on motive is what drives what we hypothesize likely lack of trust. We actually didn't see that, but it got very interesting as to why.
Thanks, Ali. So Fred, tell us the Parkland story. Why did you decide to get involved in here, and what's been going on?
Yeah. So, Kedar talked about measuring trust and how difficult that is. And that was a big issue for us because we talk a lot about it, but find it difficult to, say, where is it, and how can we tell if we're doing better at it. And so when you look at the work that we do, we're the safety net for Dallas County, big public system, in addition to for the individual healthcare of working one-on-one and assessing risk and managing chronic disease and that sort of thing. We also have a public health role, and so big issues like vaccinating the public and communicable diseases and mass screenings and things like that. Those are all things that count on having the trust of the community to be able to do that work. In fact, when we do our community health needs assessment, that comes out loud and clear. In that assessment, where we probably do over 40 focus groups and hundreds of surveys, trust came out as a top issue in terms of what impacts the community experience with healthcare. And so knowing that it's an issue, it's hard to define, And then just as a public entity, so much of our support depends on the public and the public feeling positive about Parkland and trusting the work that we would do. So, so with that as sort of a backdrop, we're looking to learn more about, what specific interventions that we're doing, how we're interacting with the community. We do a lot of that. We have a lot of conversations, a lot of programs, but is there a way to quantify and to look to see, are we focusing on the right things? Are we moving some of those key drivers that would increase trust? And so that's sort of the impetus for us getting into it.
And has this, the framework that Kedar showed, the beginning with the ARC framework and then moving to structures, have you instantiated that? Has that been?
Yeah. So when we look at that, it looked familiar, because a lot of the work that we do, it's not divided in exactly that way, but engaging with the community and sort of listening and learning what's important to the community, then specifically addressing it and going back with that. And so we can point to some specific programs where we've done that work, but for this specific project, so we've got to come to the table with a project and say, okay, what are we going to do? And our team, I talked to some of the groups at the hospital and found who was interested. It was our team that does a lot of community outreach and conducts our community health needs assessment. And so they were interested in doing it. And the initial proposal was not really focused on the trust issue itself. We have an asthma program where we go into the community and sign people up for this this texting program, and so they look to use that program as a proxy for trust. How many people could we enroll? How many people could we get on the right therapy? And then use flu vaccine as sort of the measure. And if we were moving the needle on that, then we would assume we were capturing the community's trust. And I tell you, it's been really helpful. Our team has told me, I'm not on the team, but I meet with them and hear the experience. So, they totally shifted their focus from those kind of numbers to as they talk to parents and talk to community health workers, to let's try to get at and understand what those drivers of trust are. So the assumptions that they had, that the community health workers, naturally they trusted Parkland because, they were community health workers. They were doing great stuff in the community. And so that wasn't going to be the issue. The issue was misinformation and how to get access to appointments and things like that. But as they talked to them, they totally shifted their line of questioning to, what are the barriers to trust? How do you feel about the health system? And they found things like, they didn't feel part of the team. They had trouble with access, feeling heard. And they said, if we have trouble getting somebody into a clinic that we're out in the community working and representing Parkland, and then we have trouble getting somebody in, that's embarrassing. And if we don't get feedback on the referrals, and so then we may not be inclined to refer to vaccination because that's just going to be one more thing that we fail at. So you can see with that single program already how you can sort of generalize these concepts to other parts of the system.
I'd point out one thing here, and as participants, we were able to choose, right? Whether we're going to focus on trust between the system and the community, which obviously has a lot of merit. We've talked a lot about this here, or whether we want to focus on trust within our teams. And I think, Fred, you took the first path. We took the second. We've both we both shifted a lot. But you told me as you told me yesterday, you shifted into the team world, right, from the community focus. Why?
Well, I think just what I mentioned. We went in with certain assumptions that we were good on the team side, And when we started talking to our community health workers, they didn't feel as positive about the team piece itself. We haven't done the providers. We haven't, so we'll do a series of focus groups with them, but we realized that with that one group itself, we had some work to do.
Yeah, and observationally, I think this was a trend across all, so you're right, Ali, there's two parts of this. We looked at both trust from the perspective of how does a hospital or health system develop trust with the community, and then also how do we build trust within a care team as you're describing. And I think there were 8 systems, as we always start small when we're testing something or validating something externally. And so we had 8 systems that started to do this, including the 2 that are here on the stage, to do this with us. 6 out of 8 of them chose the path that Fred is describing of going with an external partnership, trying to build trust with community organizations or with specific communities around a health condition, whether it was vaccination or there's a lot of folks working on maternal and child health, particularly in the Black community. There's folks working on sickle cell disease. So there's lots of different specific types of condition-specific or disease-specific or health system-specific or relationship with a particular community that they were trying to build relationship with. And almost all of them have actually shifted at least part of their work to also building more relationship and developing a deeper level of trust within the team. Because I think this notion that we can't really engender trust with a community unless we have a trusting relationship within a team has become a key observation of the collaborative.
What's your reaction to that, Kedar? Is this confirmed stuff you thought in advance, or is this a new learning?
I don't think our prediction ahead of time was that these were relatively independent ideas, actually, that you could pursue trust in the community, trust within, in some ways as separate paths, which is why they're organized that way in the model that I showed you. But in fact, there seems to be a dependency, or at least an interrelationship between them. That wasn't entirely surprising to us, that there was a relationship between the two. I don't know that there's a sequentialness to them. I don't know that you have to pursue the team first and then move to how you're going to work with communities. They could, I think, operate in parallel. But there's clearly a relationship between trust within an institution and its ability to form trusting relationships with the communities that it hopes to serve.
I can't help editorializing that. So in other IHI work on patient safety, we've had an experience with a wonderful organization called East London Foundation Trust in London, which is the same story on the safety side. They started it's probably a top performer for anything IHI has ever done. But the East London Foundation Trust very soon began realizing that unless the workforce was safe, they were going to be stymied on the community side. And so they began their work with safety for the workforce. I doubted that was the right place to start, but I was dead wrong. It really has been a remarkable story. So what are the next steps here? Where are you going to go with this? And, if we were to meet in 6 months or a year, what would have happened in your organization? Ali?
I mean, I think we're spending a lot of time. And I think the only reason that we had any insight into sort of not going down that path as an organization that, like Fred's, like many of ours, that obviously spends a lot of time in the community, that has 6 to 8 folks at every center who are doing this work either as community health workers or as like community relationship managers. I think the work of that team investment we had seen from our partnerships with Krasinski and the AMA joint practice work, that we knew this is very easy to skip over, right? So we didn't know what we'd find. But I think what we have found so far has been really in and around. So we went purposely to our hardest place. We also went to
the hardest place.
So we looked across the country, across our 75 markets. We saw where are we seeing largest discrepancies between that level of sort of belief and support from a manager versus the organization. Where do we see the biggest challenge of engagement, particularly overall engagement that we track 3 times a year? How does that relate to what we know from the AMA organizational biopsy and whatnot, from burnout scores, and providers, RNs, front desk, medical assistants, scribes, sort of across that cohort to see what's there. And for us, that was actually one of our most successful markets, Dallas-Fort Worth, where we opened 11 clinics in the pandemic. They grew like the dickens. We serve incredibly difficult communities, parts of the community in Dallas and Fort Worth, and there's bursting with patients. But where we'd seen there was just you could walk in, you'd see something's amiss, right, from a cultural perspective, and not really sure why. Because for us, the hypothesis was, maybe maybe they feel like we're too focused on sort of making sure that we're checking all the boxes, right, in how we make sure that we're closing HEDIS gaps and doing the right things from a chronic disease management standpoint. What we found is that it's not sort of the sort of lack of trust from an organizational perspective at that level, at the ground level, is really around trauma, or from opening a pandemic, going super fast, not being able to find that nurse, right, when the clinic needed to go from 2 nurses to 3, or losing an MA after 2 weeks because they could get a better job working for a COVID home testing company down the street, right? Sort of what we saw from workforce shear across was incredibly magnified in Dallas. Well, and then seeing that perceiving that teams are not moving fast enough. It wasn't a budget issue, but why couldn't we get these things? What was promised to us? And like, where are those resources? And then realizing that the resources came eventually, but there was no acknowledgement. No statement of like, hey, we messed up. Or hey, this is a good example of how we as leaders did not know what you were doing on the ground and what's feasible and what's not, right? Like, what did you show a flexibility? For us, what we've seen is that it comes down to core issues at our care team levels around, do they feel autonomy? Do they have a sense of that their voice matters when large decisions are being made across the organization? Do they feel like they have a forum to even give that? And so we are spending a lot of time in that sort of reparations framework of saying, how do we acknowledge and be humble about admitting when we've been wrong? And what does it have to look like to be sincere and then carry forward? So it's deep work right now.
You're nodding, Fred.
Yeah, I think we're thinking along the same lines, and and I'll admit I'm not as close to the decision making on the team as I mentioned. We'll check in with them and see how they're doing, but I think where we're headed is, at least initially, these rapid cycles on smaller items, and so for instance with the community health workers, what they've said is what they'd like. They see as measures of success are their issues heard and are they responded to? So I can imagine, for instance, if they've been hesitant to schedule vaccines because of concerns about referral, well, perhaps they can have the ability to schedule a visit themselves. Give them control over that. It's an easy it's an easy intervention, and so I think what we'll see is something like that with community health workers. We still have the interviews to do with the providers. So we're still early on in the process, but identifying those issues where they don't feel heard, they don't feel part of the team. They identified a metric like turnover. We talked about that and sort of the hazard of using that, the pluses and minuses of that, but kind of hear from them to say, what do you see as, what does it look like to have more trust in the institution, and what can the institution do to foster that?
One thought I had actually on our first day when I was listening to the speakers on the stage was, IHI has this thing that Don and I both participate in called the Leadership Alliance, and in the Leadership Alliance we do this somewhat I think humorously titled idea of get rid of stupid stuff, right? This notion of taking the common headaches, and several people from the stage describe this idea of that being an enormous trust builder with different parts of your system, your ecosystem. So get rid of stupid stuff. We call it breaking the rules. And there's all kinds of myths. I think David Baker was talking about the myths that we construct to protect the way that we've always done things without listening to the people that are in the work and the pains that some of those things actually cause them. And when you start to listen to those things, and you start to unravel the source origin of those ideas as to why we prevent people from visiting or do all kinds of other stuff in our institutions, we start to identify things that would be enormous trust builders, actually, that we can we very rapidly address through the work that we do. And that these ideas, whenever we run a breaking the rules effort, we source from 60, 70 systems around the country. We source hundreds of small, what people sometimes call pebbles in their shoes kind of issues that are enormously vexing to frontline team members and causing countless hours of wasted time and effort. And when leaders start, like these guys, start to actually pull those things off the table and say, you don't need to do that this way any longer, that's the kind of thing that starts to build relationship and trust and creates a new foundation for a different kind of relationship in the environment.
This is in Tate Shanafelt and Steve Swenson's work on burnout. This Pebbles idea is one of the components of the changes that they found have been most important in their case, reducing burnout, but it seems slightly related to this trust matter. I was remembering Eric's comment on the first day's little story about long distance phone calls, where he had to go through all sorts of hoops to get approved, and then turned out they had a unlimited contract.
Talk about stupid stuff.
In the ARC framework, it begins with acknowledgement, or is it acknowledgement or apology? What's
Acknowledgement.
Acknowledgement. So, Fred, how has that gone? I mean, that you would.
Again, we're. I was intrigued by your question on the acknowledgement and apology the other day about how do you do that practically, because do you have one big apology? You can have a system level apology, or is it a series of small? And I think, practically it's a process, and you're going to keep doing it as you acknowledge and apologize. And so, so as the phase that we're in right now is with those community health workers that are their patients and their employees, and so acknowledging, listening to what their concerns are, and here being eye-opening of the assumptions that our team went in with were, that group is going to be sort of on the team and feeling positive, and then you sort of uncovered where they didn't feel as much as part of the team, and so I think in small steps, that's one group. I think you'll hit that with providers. As you do the discussions with patients, you'll find the same thing. In fact, it's lining up with some of the earlier work. We did ABIM work, Kavitha's group here did work on vaccines with residents, and having focus groups with residents and having focus groups with patients. And again, the assumptions don't line up. Where it's kind of the theme of the residents' assumption was people weren't getting vaccinated because of misinformation. They couldn't weigh the risk benefits and those sorts of things. And when you talk to the patients, what they said is they wanted to be seen by a provider that they trusted, and that knew. And it's funny, I was reading this report the other day, and I filled in the blanks. It said they wanted to be seen by a provider they trusted and knew and I automatically thought the next line was knew their facts and information about the vaccine, but it was knew their history and their medical history and their where they came from, and so it's funny. We're programmed to think it's the science and the information, but what the patients are telling us is it's the relationship and feeling the respect.
They feel known and seen. Yeah. Right. Has this taken a piece out of you? I mean, to go through a whole process where you're constantly involved in kind of a little bit of mea culpa. What's that like for you personally?
I think it's important it's so important for the institution, if we're going to do the work, that if we really are going to be in the community and improving the health of the community, and we can be tone deaf to what the real issue is. It's easy to go to the science and fall back on that. But I think the more we explore it as an institution, and we have a number of forums where we talk about it. We've done things like the 21-day challenge, where every day you get more information about some of the history of why we've got why we have the disparities we have and how deeply rooted that is. So it is. I mean, you've got to go in pretty humble to have the conversation and realize that if we're going to get it right, that you talk about giving away power, and how do you, as people with the power and making the decisions, that's a hard thing to do, but it's an important thing to do if you're really going to gain the trust and ultimately sort of do what we want to do, is improve the health of the community.
Aletha Maybank, the Chief Health Equity Officer at the AMA, and a friend and colleague who we work with very closely on the Rise to Health Equity Coalition that IHI runs nationally. She uses a quote. I'm going to paraphrase the quote here because I'm going to get it wrong, but it's something along the lines of, "We may not have built the house that we're living in, but nonetheless we live in the house that we're in." And the point of the quote is to say that the conditions that we are facing, a distrust that we might experience or encounter, may not have been of our own making necessarily individually, but we inhabit that house now, and it's our responsibility to start to undo aspects of the distrust or challenge that we might be facing, whether it's due to racism or structured injustice of some kind, or frankly, negligence and impatience in the past. But the opportunity to undo that is ours whenever you're sitting in the leadership chair. And I think it's Don, your question is a good one, because I think I've watched health system leaders working on whether it's vaccine uptake or equity work struggle with this question of apologizing for something that they may not have directly been involved with. They may not have even been in the system when the past harm took place. But nevertheless, they're in the job today, and that job requires a humility that, Fred, you're describing, and the ability to transparently acknowledge that harm and speak to it and apologize for it is critical.
And I think, the closer, as you said, we haven't lived those experiences, but the closer you get to the stories, the easier it becomes. I mean, I think we all have to get closer to the stories, the personal stories, and understand the harm that, that's been done. And the closer that you get to some of that, the easier, the less defensive you can become, and recognizing that, we do have to acknowledge and apologize.
This is the proximity that Brian Stevenson talks about.
Right.
So you're working on a for-profit platform. Ali, does it change there, or how do you think about that?
Honestly, Don, I think surprisingly no, right? And which I think would potentially be interesting for us to unpack. But I think when we spend a lot of time talking about scar tissue with patients at Oak Street, right, against the medical industrial complex. We also spend a lot of time, as some of us were discussing last night, in and around the scar tissue that each of us as clinicians or as actors in the system have built up against the system itself, right, as a means of survival. I think we find across many of our systems today, right, that there is a hunger, particularly at the ground level, for authentic leadership and a general sense of skepticism that will ever come, right? So our teams are still programmed to think about a lot of rhetoric, right? That what a leader is saying is rhetoric, right? At Oak Street, one of the manifestations of our values is we try to say, it's totally okay to go off script, but and how do you stay on the dance floor, right? In terms of doing the right thing for a patient. But then our teams feel caught in terms of saying, well, the protocol says I have to do it this way, right? I'm being asked to go follow this pathway. I'm being asked to sort of return this call in 30 minutes, so I can't deviate. And so from us, I think that and we've touched on this a bunch of times the past few days, but the authenticity gap, right? So as a leadership perspective, how are we able to look ourselves in the mirror and say, we are sitting in this with our teams, listening, and then giving them modeling and giving the permission to say, stop doing stupid stuff, right? Or just go solve this, right? I run into this, I think even my first week at Oak Street, we ran into this where a patient with a large diabetic foot ulcer needed to come in, and the clinic wasn't sure what to do because she had to care for her grandchildren that day. And so I said, okay, we should bring our grandchildren. We do the transportation. And the driver says, well, then we need a car seat because one of the grandkids is 4. I was like, okay, we should buy the car seat. And then the practice manager says, well, then the driver won't install the car seat. That's not in his protocol. And I was like, I'll install the car seat. She, her foot wound left unattended in a full risk model is going to cost us $45,000. We are across the street from a Kmart, still there. And let's go buy the car seat, right? So, but that is, that team will always, it still talks to me to this day, because I end up floating there a bunch for clinic around what that sort of uncovers. But we as leaders go back and we pat ourselves on the back, oh, what a great day, right? And we tell this story 2 years later. But we forget that our teams need those kinds of reinforcements, those kinds of moments every day as they are going through their own trauma-informed process of learning how to operate a different system.